Hello, this is Dr. Amir Meron. Thank you for watching our bariatric seminar for University Bariatrics. Today, I'm going to give you a quick overview, the rationale for surgery, how we select patients, what are your surgical options, including those that we don't offer, what are the comparative risks and outcomes, how we run the program, and a segment on frequently asked questions. The purpose of this seminar is to answer about 95% of your questions. And this way, when you come to the actual appointment, um, there's a lot of time to ask the questions that were not covered in this setting. Um, this is the most recent updated map of obesity rate in the United States, and I'm mainly showing it to you to show you that you're not the only person, and this is quite a prevalent problem. Obesity is a complex disease. It's a combination of genetics, environment, the foods that we eat, the processed foods, microplastics, everything else that's coming out now, as well as a lot of personal behavioral issues. Obesity affects every single organ system in the body from head to toe, from lungs, fatty livers, cardiac problems, diabetes, GYN issues, arthritis. Uh, Different cancers have a higher propensity in patients who have obesity, as well as a premature death. Obesity has a significant personal impact, daily activities, your mobility, health, financial burden, co-pays, deductibles, missed works, etc., as well as the less tangibles, such as the self-image and emotional abuse. Some of these comments may look quite familiar to some of you. You may have heard this before, including from your own physicians. The fact is that vast majority of patients have been on a plethora of diets going back years and decades. They've been on a lot of different medications, including some of the newer GLP-1 agonists. It's a vicious diet cycle. The patients go on a diet, they get a famine response. Most patients don't find this sustainable. They essentially fall off the pathway and then they gain the weight that they lost back plus more. And this keeps repeating and repeating. Yo-yo dieting is the other terminology that's used for this situation. And I'm sure a lot of you are quite familiar with it. The issue is the metabolic thermostat, also known as the metabolic set point, that every time you gain weight, that's the new set point, and the body will significantly resist you trying to go back to where it was before. It always wants to spring back up to where it was before. Your options are really just the established diets and methods that you've tried in the past, the newer medications, or the most effective one, which is bariatric surgery. The GLP-1 agonists have got a lot of news recently, as you're quite aware of. They're the newest class of medications that we have now. They're very effective when compared to the old drugs. They're different kinds, and they're all injections. Pills are potentially coming down the pipeline in the future. They're heavily advertised, as you quite well know, and they all have their own celebrity influencer promotions. The issues that patients run into are the cost, insurance non-coverage. Some resort to compounded pharmacies, non-branded types, which I highly caution against because you don't know what's in them. There are a lot of fake online ones, but very importantly, they have a lot of side effects and complications. And as years go, the list of these side effects and complications goes up, which is why I don't list them here because this will get outdated within a year. What happens when patients stop these medications is that they get regain all the weight that they had lost. The overwhelming majority of patients do not stay on these medications beyond 2 or 3 years in real world data. And when they stop that, all the weight comes back plus more, similar to the past. There are some that are able to keep the weight off. They may go on intermittent shots here or there, but the vast majority, it doesn't work as well as they're advertised. Or once they lose the weight, they stop the medication, the weight comes back. In rigidly controlled studies, the amount of weight loss is up to about 20% of the total body weight with some of these medications, versus if you look further up with the sleeve and the gastric bypass, they are still higher. But in rigidly controlled studies, that means that companies run the studies, the foods, the dietitians, the transportation plans, etc., all rigidly controlled, and patients don't incur any costs. Um, these medications do quite well. In the real world, however, what has been seen is that the average weight loss is about 5, at the most 10%, which is far lower than what you get with the surgeries. So most recent studies that are going to be published by the time this uh, seminar is watched, surgery still has a much better outcomes than medications do, including the newer GLP-1 drugs in the real world. Um, this is a consensus statement from 1991, way back when. It's still the same in 2026. And again, more data gets published in the real world data, pharmacy data, etc. Surgery is still the uh, best way. The benefits of surgery are, as you see here, resolution of medical issues or significant improvement, sleep apneas, asthmas, heart disease, high blood pressure, heartburn, joint pains, cholesterol issues, fatty livers, diabetes, and in women, polycystic ovaries, and significant reductions in mortality and significant improvements in quality of life. If you look at it, if you look at obesity as a giant hill, you can go at it with surgery. You can go at it with these new medications, or you can go at it the way you've always done it. The fact is that you probably have to do all. It's very similar to cancer therapy. The way I think this will go is some higher weight patients, higher risk patients, to downstage them. They go on the shots to reduce their weight. Surgery comes in as the primary modality. And then some patients may need the shots after surgery to get a bit more weight loss once the weight loss from surgery has maximized, or help them turn off the food noise that sometimes comes back. Patients have to be aware that there's a lot of fallacies that are out there about surgeries or even medications. The goal of the surgery is to not make the patients thin and happy. It will not stop patients from being irresponsible. It does not cure eating disorders, and it's not a fix-it-all. Surgery is only a very powerful tool to help patients manage their morbid obesity when used in conjunction with permanent changes in eating and lifestyle habits. No changes, the surgeries work a bit and then they stop. All the surgery does is that for the same gallon of effort, gets you more miles of weight loss, but you still have to put in the effort as the patient. It really falls on you, your personal responsibility and taking charge of the process. Those who don't do well, and you might know some of them, they're looking for quick fixes. They're unwilling to change. It's never their problem or their fault, valuing vanity over health, and having what's known as unrealistic expectations. This is not the goal of surgery. This is the goal of surgery: resolution of medical issues, improvement in life, enjoying life, going on about activities that you're not able to do as it is right now. So, how are patients selected? As you quite well know, you plug in your height and your weight into an online calculator similar to this one, and a magic number comes out, which is body mass index, which is not the best way to do it, but this is currently the only way that's being done. You have to be BMI over 40 or over 35 with medical issues that are listed here. Lower body mass index, we think the surgery is indicated. There is currently some insurance coverage for some of those patients, uh, especially if they're diabetic. But for the most part, insurance companies don't cover the surgery for body mass index below 35. If you do this at home and it's close, you have to realize that when patients come to offices and get formally heighted and weighted, they tend to be a bit shorter and heavier than they think. So definitely get yourself officially heighted and weighted either in our office or through your primary care physician. And you can get a better idea of what your body mass index is. So again, in some health plans cover BMIs of over 35 with no medical issues or over 30 with medical issues, about five below the current standard guidelines. And in some ethnicities, as low as 27. And in certain cases where patients have to have transplants, operations on their spine or joints, but they can't because of the weight, sometimes you can get insurance coverage. But it changes based on the plans and their guidelines every year. I do require patients to have a primary care physician. There's a significant amount of pre-op medical tune-up that goes into these cases. You may not need additional specialists. There's need for dietitian psychologists, which we talk about at your visit, and you have to start lifestyle changes prior to surgery. That includes absolutely no cigarettes, tobacco of any kind. Patches as part of quit smoking program will be okay. Alcohol and medical marijuana use have to be minimized. Obviously, no illicit drugs and some form of a physical activity is needed. So, what are your surgical options? These are the four main operations out there. The bilipancreatic diversion duodenal switch, bans, although barely nowadays, sleeve gastrectomy, gastric bypass, which are the primary operations. The more risky the operation, the better the weight loss, but then again, you buy yourself more risk. And if you look at it, the gastric bypass and the gastric sleeve are in the middle. The sleeve gastrectomy is currently the most common, most popular option. If this is your normal anatomy with food going down the esophagus, goes in the stomach, gets churned like a meal into digestible stuff, goes into a small intestine for absorption, and into the large intestine for absorption of the water. In the sleeve gastrectomy, about two-thirds of your stomach is physically removed, but none of your gut is rerouted. It's just making the stomach much smaller, but the portion that is taken out does have some hormonal activity, which is why a lot of patients have the same benefits as the bypass. Um, I've been doing sleep since 2007, way back before it became popular, back in the heyday of adjustable gastric bands. And this was something that I offered along with my colleagues at UCLA when I was there, um, as an alternative to lap bands. Again, there's no hookups or intestinal rerouting. There's no foreign body. The results and benefits are close to the bypass. Metabolic side effects are very mild, if at all. You can take any medication through it. The true long-term complications are so far rare. And I think for young women with potential for pregnancy in the future, this is the best way to go since if you start getting abdominal pain while you're pregnant, I can give you significant assurance that it's not from your sleeve. But with the other bariatric procedures, it could be from them. So I think for young women, potential pregnancy, this is the way to go, unless there's some contraindications. However, I am removing a healthy part of a healthy organ. As far as diabetes and polycystic ovaries are concerned, the gastric sleeve does have a lesser punch than the bypass. It's truly irreversible, that part of the stomach that's removed. I can't go put it back in. 10 to 30% of patients can get new onset of heartburn that they did not have before or had it and comes back. Um, Patients who have known esophageal dysmotility or have a known Barrett's esophagus, and we can talk about that when you come to the office visit, gastric sleeve is contraindicated. Next operation is the tried and true gastric bypass. Again, esophagus, stomach, small intestine, large intestine. In this operation, everything stays there except things get rerouted. So a small portion of the stomach is used The rest of it is divided, but it's still in the abdomen, and about a third of your intestines are rerouted. This is a hybrid operation. It has a very long track record. It's as old as I am. It's well studied, results are durable, and the benefits, especially with diabetes, are weight loss independent. And that has to do with the bypass of a significant, uh, hormonally significant part of the small intestine called the duodenum and proximal jejunum, where 90% of the absorption and where a lot of the GI hormones are, um, that's that area. This is interesting, the same area that the GLP-1 medications act on. So this is how we think this surgery works. There's also change in the microbiome of your GI tract, which seems to help with weight loss as well. It is, however, a more complex operation versus the sleeve or the band. There's a lifetime risk of bowel obstructions, marginal ulcers, potential for strictures at the hookups. There are some medications that you should not be taking at all with a gastric bypass, and the anatomy gets altered, and therefore sometimes, depending on which hospital you go to, if they're not familiar with the nuances of gastric bypass, they may miss a few things. So these are the potential cons, but the very, very low incidence of all these things that I put on this slide, but you should be aware about. There are some nutritional issues after gastric bypass in terms of vitamin and mineral absorption, but the replacement is not onerous. And most patients will just do with a multivitamin, a good multivitamin, calcium, and maybe extra iron. And that's about it. Very uncommon are significant iron deficiency anemia to the point of needing iron transfusion or even blood transfusion. This seems to be mostly in women with heavy menses. I've rarely seen this myself. There are case reports of significant hypocalcemia and vitamin D deficiency. Again, very, very uncommon. Dumping syndrome, everyone worries about it, but it's actually not a dangerous situation. It's a form of punishment for non-compliance, and not every gastric bypass patient gets it. Um, it does have some nasty side effects with in terms of your heart racing, getting abdominal pain, cramps, diarrhea, etc. But then it goes away, and it has to do with eating refined carbs um, that dumps into the system without slowing down. But again, not everybody gets this, and it's not dangerous. There are some patients, however, that the diabetes overcorrects, and they have to be maximally medically managed as well as dietary managed. And there are rare cases that you have to undo the gastric bypass if they don't respond to conservative management. So, how do you decide between the two of them? Primarily, it's your choice, somewhat your medical history, new findings during your preoperative workup. You look at other life factors like pregnancy that I mentioned, job factors, traveling, etc. And it's not a decision that you have to make right away since the workup is the same. If you can't decide, I usually defer to or default to sleeve gastrectomy because you don't burn any bridges and you can always convert it to another malabsorptive procedure down the road if that becomes necessary. That's why I've always called it the Honda Accord Toyota Camry of the bariatric surgeries. It's good enough for 80+% of patients. There are other procedures out there that I don't offer for a variety of reasons. The plication, also known as the wrap, the balloons, which fizzled out, endoscopic sleeve, which you can look into. Currently, insurance doesn't cover it, but it may change in the future. There's a version of bypass called mini bypass or one anastomosis gastric bypass, which I don't offer. The duodenal switch is an approved operation, which is gastric bypass on turbo or steroids. It works really well, but it has significant side effects and malnutrition issues that you have to be aware of. Same thing for SADI, and I've never offered the lap band. And as I mentioned earlier, I did the sleeves going back 20 some years um, as an alternative to it. Um, the problems and complications with adjustable gastric band were well known even back in its heyday in the 2000s. And some of us knew this would happen. So I tell patients who have it to either use it or lose it. Either use it, get it adjusted, go up and down on the volume and make it work, or just get it out because these bands do have complications and the reoperation rate after bands is 100%. So, what now? Is it worth the risk? You can continue on a variety of diets that you've been on with the usual vicious diet cycle. You can go on shots and pills, old ones, new ones. You can go for surgery, which is still in the real world data, still the best way to go. But be cognizant that there's no one best operation for everyone. There's nothing that's risk-free, and none of them are effort-free. You can't just have surgery and assume that the weight will come off on its own. You can seek a lot of medical opinions, and there's quite a bit of it out there. There's a plethora of misinformation out there. If you know people who've had surgery who did great or did not do well, does not mean that you will be the same, and you're the ultimate decision maker. And you have to make that with better knowledge about the procedures, risk benefit analysis, and have some unpressured discussions with your bariatric surgeon, your support system, your other physicians. All surgeries have this potential complications. You have your foot operated on, you can have these complications. One thing about me is that I don't do MAC surgery. This is not a meal. I really focus on outcomes and perioperative safety. There's a lot of T crossing and I dotting that goes into it. I do not utilize PAs, nurse practitioners, or other mid levels. I do all the decision making on all the operations. I do not use surgery centers. I only use tier one hospitals for my own reasons. And there are pathways that patients have to follow. When I pull patients who have had surgery in the past and are more than a year out, this is what they tell me. So what's the process? Once you finish watching the seminar, you can contact us to make an appointment. If not done already, you come for the clinic visit, which can be done on Zoom or can be in person. But for sure, you will see me in person at some point before surgery. We'll plug you with a dietitian and psychologist. You'll have to see a primary care and maybe other physician consults, depending on your medical history. There's some routine and additional tests that you'll need to get done. Um, Once the packet is complete, then we submit to insurance. Um, Authorizations have variable waiting periods. Usually, if the packet is complete, the waiting period is very minimal. Um, if they deny for some reason, we'll appeal it. We have to find out why. But again, packets that are complete pretty much never get denied. And then you come for the pre-op appointment and the actual surgery. Obstacle one are the insurance companies. But the biggest obstacle we've noticed is the patient who does not do what's necessary to do, or their physician offices who don't forward the information, even though they've had the necessary workups and the tests done. So this has been our biggest obstacle and delayer of surgeries. As I mentioned, I do these procedures either at Los Robles Hospital or St. John's. Both are tier one facilities with private rooms. St. John's is actually a bariatric center of excellence for pretty much all the health plans. Surgeries are 1 to 2.5 hours. People in the hospital 1 or 2 nights. I don't do same day surgery except for band removals. You're up and around about 4 hours after surgery. You've been a liquid diet at discharge, and pretty much by 1 month, you're on solid food, eating out with your friends and family, and all the post-op instructions you will learn prior to surgery. You'll see me within a month after surgery and every quarter with lab work, which I'll tell you about it when you come to office. And then follow up after 1 year is really on you to follow with us, the dietitian, go to support meetings, etc. People who really stick with the program and follow things to the T, they have the best weight loss results. So we highly encourage that. Now, some frequently asked questions. I've been told my BMI is over 40. I'm at least 100 pounds overweight, but I don't have any medical issues. Well, vast majority do have fatty liver. This is becoming a major medical issue that more and more patients are being diagnosed with fatty liver, and some have even worse types of it called fibrosis and NASH. Um, this has been looked at. Patients who were denied insurance, usually within 3 years, they have a 30 to 40% chance of getting the medical issues that they did not have before, such as diabetes, sleep apnea, high blood pressure, cholesterol issues, etc. So again, fatty liver, quite prevalent. Medical issues will come downstream eventually. Uh, Patients say that I've heard that post-op period is miserable and they can't enjoy life except for smoking. That is not the case. I typically tell patients that about a month or so after surgery, you can go to Cheesecake Factory. You can order from their better, what's at least now known as the Skinnylicious menu. You box a half, you eat a half, and you have a spoon of your family members' cheesecake as well. So it's not deprivation. One thing about alcohol is that it's a cheap date and a quick DUI. Um, you have to be very careful with this because people could do a whole glass. Now they can only do 1/3 before they get buzzed. This is also a very fast way to gain all your weight back. It's also the most prevalent form of addiction replacement, where patients replace food with alcohol. So this is something that has to be addressed before surgery if you do have an alcohol issue. And surgery should not be done until that issue has resolved. And be careful afterwards as well. Patients say that I've heard that people have belly pain, vomiting, diarrhea, sick, wasting away after bariatric surgery. That is not the case. Usually things like pain, nausea, vomiting, diarrhea is because they're eating the wrong things. Too much of the wrong things or eating them too fast or a combination of all the above. However, there could be technical issues that need to be worked up. So this is extremely uncommon. With the duodenal switch, patients do get diarrhea, but I don't offer that. So with a regular gastric bypass or the sleeve gastrectomy, these are really unheard of. And again, this is something you can discuss with former patients, which I'll talk about in a minute. Weight regain, everybody gains a bit of a weight back. It's like a bouncing ball. You, the patient, control how far the ball comes up. The surgeries don't expire, and the degree of weight regain completely depends on your compliance, your maintenance of lifestyle changes, how well you follow up with dietitian, go to support meetings, etc. Period. What I have seen is, based on results of serving previous patients, patients who lost about, say, 100 pounds do expect to gain about 10, 15 back. And some actually do want to gain some of it back because they feel better at that weight. But really comes down to patients, their compliance, and how well they can manage the diet. And if things start going the wrong way, how soon they address it and come and see us and talk to dietitian and the like. Doesn't mean you're going to gain all your weight back just because you had gastric bypass done. He's one of many, many examples out there. Is it going to cost an arm and a leg? Well, I do not have any program fees. There are no hidden fees. We are a network for pretty much all the PPOs, and we also Medicare. And if there's a need to do a cash rate, competitive cash rates from the two hospitals are offered, which I won't say what it is now because the rates keep changing. I typically tell patients to expect to burn through the deductible and There's all these other costs that sometimes insurance covers and sometimes it doesn't. But you have many options for dietitian and psychologist, which we'll talk about when you come to office. And the supplements, which are not onerous, and all the usual pre-op testing, doctor visits, etc. So it will not be free, but the cost is not onerous, and typically patients recoup their um, cost within a year or two from less doctor visits, less medications, less being sick, less hospitalizations, and the like. I have a very transparent program. What you see is what you get. Um, we always bill insurances. We don't have any ownership interest in any labs or any facilities. We don't get 6,000 different tests from 10,000 different doctors. There's no over testing either. I'll keep it to a minimum required, even though we do a lot of T crossing and I dotting. Typical scenarios that patients have to pay out of pocket for surgery are listed here. But paying out of pocket does not put patients in front of the line. The same T crossing, I dotting process is done, and I still do them at a tier one hospital and not at a surgery center, even though it will be cheaper. So I really, really emphasize risk minimization, good outcomes, and patients doing well. When can I go back to work? I tell patients to do 2 weeks minimum of me time, even if it's working from home on a computer. 4 weeks for more stressful jobs, physical work jobs, 6 weeks for extreme cases, rarely above that. So most people, 2 weeks at the most, 4 weeks. And yes, we do fill out EDD forms and all kinds of forms. And no, I don't charge for those, and those are done on a gratis basis. Can I drive? Yes. You can't drive from here to Seattle, for example, after surgery, but short trips are fine as long as you're not taking narcotics. Can I fly? Ideally, not for 2 to 4 weeks after surgery. It's the blood clot list plus bad food on the planes, dehydration. Try to be in the area, but if you have to travel by plane, it's fine. The staples we use for the surgery also don't set off alarms at the airport, so you don't have to worry about that either. That question has been asked. Sagging skin, it can happen. Overwhelming majority of the patients have not had any cosmetic surgery done afterwards. Some do. There are many options for that. I don't personally offer those surgeries, but there are a lot of plastic surgeons who do it. Sometimes insurance covers parts of it, sometimes they don't. But again, that's between you and the plastic surgeon. But typically, I tell patients to wait a year and a half from the surgery before they embark on any excess skin removal or other cosmetic procedures. I'm an expert in hair loss, as you can tell. However, unlike me, your hair will thin but grows back. That's usually early in the course of surgery, first couple of months or so, from lack of enough protein, not taking vitamins, etc. But if it goes after 3 to 4 months, then it's not related to the surgery. So you're not going to look like me. Don't worry. Where can I get more information? Definitely not from these resources. Please avoid social media when it comes to bariatric surgery. Do not watch what people put there. The more legit sources are here. Uh, the ASMBS is the Society of Metabolic Bariatric Surgery. There's a lot of modules and stuff there for patients. You can go watch them, and it's free. You can go to emi.com or goemi.com. You put in University Bariatrics as the provider code. There's a lot of modules that you can watch there as well. These are also free. And not just about bariatric surgery, but about other procedures as well. Um, We will give you a what's known as the blue packet, either a physical copy or an e-copy for those of you who have your first appointment on Zoom. And that has a list of emails of former patients who have agreed to be contacted. And this is not a censored list. It could be everybody in it, sleeve, bypass, did great, didn't do so well. Everything's there, and you can email them, hopefully blind copy, and get some inside scoop and information. So Again, this is a very WYSIWYG practice. What you see is what you get. We have nothing to hide. So, in summary, surgery is a very effective and durable tool. It does require permanent changes in lifestyle and eating habits. I really believe in pre-op education and preparation, T crossing, I dotting. Um, do a careful choice of your surgical options and where you have your surgery done. I can't emphasize that enough. It's up to you how you want to go. Keep things as they are or move on with your new life. Next step is to contact us. If you don't have an appointment already, you can text, which is best way, email, or through our website, schedule it directly. Thank you again for watching our bariatric surgery information seminar. If you have any other questions, please write everything down, bring it to your appointment. You have the whole 1 hour to ask anything you like.